Hi everyone, my name is Zachary Taylor. I'm a fourth-year PhD candidate in the pharmacology program at the University of Cincinnati, and I'm under the mentorship of Dr. Laura Ramsey at Cincinnati Children's Hospital. I would like to thank you for visiting my virtual poster presentation for the ASCPT 2021 annual meeting. It is unfortunate that we will not have the opportunity to chat in person at this year's meeting, but I encourage you to contact me at one of the given mediums listed on this slide. And depending on when you are viewing this material, please feel free to virtually visit the poster walk session for pediatric drug disposition and pharmacogenomics being held on Friday, March 12th from 6 to 6:30 p.m. Eastern Standard Time. With that, I'm eager to share with you my work entitled Methotrexate-induced nausea is associated with the SLCO1B1 star 15 allele in pediatric patients with inflammatory bowel disease. Patients with inflammatory bowel disease are commonly treated with a combination therapy of anti-TNF biologic medications such as infliximab in combination with an immunosuppressive agent. Infliximab is a chimeric monoclonal antibody and is highly immunogenic, with upwards of 60% of patients generating antibodies to infliximab monotherapy. This leads to infusion reactions and a shorter duration of response, so overall reduced efficacy. Several studies have confirmed the beneficial effect of concomitant immunosuppressive therapy, such as low-dose methotrexate, in preventing antibody formations to infliximab. There is evidence that low-dose methotrexate reduces the immunogenicity of infliximab by reducing the formation of antibodies to infliximab. There have also been studies suggesting that concomitant methotrexate will increase trough concentrations of infliximab. While effective in combination therapy, the major limitation of methotrexate use is the accompanying nausea and liver toxicity that decrease its tolerability. Exposure and side effects of methotrexate have been associated with polymorphisms in SLCO1B1, a liver transporter responsible for the hepatic uptake of methotrexate. Specifically, SLCO1B1 star 5 and star 15 alleles are considered reduced function and have been associated with reduced methotrexate clearance and increased side effects in adults. Therefore, the objective of our study was to evaluate whether SLCO1B1 alleles are associated with methotrexate-induced nausea and intolerance in children with inflammatory bowel disease. To do this, we retrospectively analyzed 278 pediatric patients being prescribed methotrexate for IBD at Cincinnati Children's Hospital. Of those, we had 203 patients with banked DNA that we were able to genotype for 3 SLCO1B1 SNPs, as seen on this slide. Patient diplotypes were determined by combining the SNPs into their appropriate pharmacogenetic allele nomenclature. Nausea and intolerance were abstracted from clinician notes, while prescriptions and demographics were extracted from the medical record. Methotrexate intolerance was defined as adverse reaction to methotrexate, which was most commonly nausea or elevated liver function tests. Unfortunately, 51.7% of the patients experienced methotrexate intolerance, and 34% of patients experienced methotrexate-induced nausea. The methotrexate dose was higher in patients with nausea than those without. Additionally, we found an association between nausea and SLCO1B1 diplotype, which remained significant even after accounting for methotrexate dose, and whether treatment was initiated with concurrent ondansetron to prevent nausea. We found that methotrexate-induced nausea was dependent upon the number of reduced function SLCO1B1 star 15 alleles. Patients with at least one reduced function allele reported a higher frequency of nausea, with concerning 4 out of 5 patients with 2 star 15 alleles reporting nausea. Now, if we take a look at our nauseous patients only, we determined that the administered methotrexate dose was similar between patients with 0 star 15 alleles and patients with at least 1 star 15 allele. This suggests that the increased nausea in patients with reduced function alleles is likely caused by the slower methotrexate clearance and elevated methotrexate exposure. And finally, we wanted to determine whether initiating treatment with concurrent ondansetron affected the frequency of methotrexate-induced nausea. As you can see, the ondansetron did reduce the reported nausea by nearly 50%, in the star 15 allele carriers, down to a similar frequency as our non-star 15 allele carriers, though this decrease was not statistically significant. In closing, our data demonstrates that the SLCO1B1 star 15 allele is associated with methotrexate-induced nausea in pediatric patients with IBD. Additionally, patients with at least one star 15 allele could benefit from a dose reduction of methotrexate to reduce their exposure, and methotrexate treatment should be initiated with concurrent ondansetron to reduce nausea. With that, I would like to express my appreciation to ASCPT for hosting this incredible meeting, and thank Rishi Mehta and Drs. Lisa Martin, Michael Rosen, and my mentor Laura Ramsey for their constant support and guidance with this project. Please feel free to scan the QR code to connect with me on LinkedIn, and don't forget to follow us on Twitter. Thank you for your time and attention.